Hello, I'm Alicia Darwin, a fourth-year medical student at the University of South Florida Morsani College of Medicine. Today, I'll be sharing a clinical vignette entitled Acute Kidney Injury, Time to Spice Up the Differential. Acute kidney injury, or AKI, is a common finding in patients requiring hospital-level care and can be caused by ingestion of nephrotoxic substances such as pharmacologic agents, toxic alcohols, and both legal and illegal recreational substances. Toxic ingestion should be considered when patients with AKI have altered mental status beyond what would be expected from any ongoing metabolic derangements. If thorough investigation does not suggest ingestion of toxic alcohol or other substances for which drug screening is readily available, clinicians should consider synthetic cannabinoid-induced AKI. Synthetic cannabinoids, commonly known as spice or K2, are widely available and often marketed as a safer alternative to street drugs, despite their association with several toxic sequelae. Here we report a case of a synthetic cannabinoid-induced AKI in a 35-year-old female with history of alcohol use disorder and cannabis use who presented with nausea, vomiting, and altered mental status. She had a history of presentations for nausea and vomiting without altered mentation. On exam, she was difficult to arouse. Once aroused, she was fully oriented but had psychomotor agitation and poor attention. Her lab evaluation was notable for elevated BUN and creatinine. Her creatinine on presentation was 4.4 from a baseline of approximately 0.8. Additionally, she had a low bicarb, elevated anion gap, and elevated lactic acid. Her CPK, lipase, liver enzymes, ketones, and levels of alcohol, aspirin, and acetaminophen were non-remarkable. Her serum osmolality and osmolar gap were within normal limits. Taken together, our workup revealed a triple acid-base disturbance consisting of an elevated anion gap, normal osmolar gap, metabolic acidosis, with concomitant respiratory and metabolic alkaloses. Her urine drug screen was positive for cannabinoids, but otherwise, her urinalysis was non-remarkable. The patient was managed supportively with IV fluids, and her renal function, acid-base status, and mentation recovered by day 2 of her admission without need for dialysis. When considering our case, there were several features suggestive of toxic ingestion-induced AKI. Our patient presented with an AKI of significant severity, unlikely to be caused by a volume depletion secondary to vomiting alone. On her prior presentations for nausea and vomiting without altered mentation, she often did have mild AKI with creatinine increases up to 1.4. While there was likely some degree of pre-renal kidney injury, it was not likely the sole contributor to her AKI. Ingestion of toxic alcohols was considered, but her presentation was not suggestive of these well-defined toxidromes, which often include elevated osmolality and osmolar gap. As our patient's mentation improved, she was able to discuss her recent ingestions, which included cannabis of unknown quality from unreputable sources. Given our findings, it was determined that her AKI and toxic metabolic encephalopathy were secondary to ingestion of synthetic cannabinoids, most likely contaminating her cannabis. AKI secondary to synthetic cannabinoid use is rare, but has been reported and must be considered given the prevalence of natural and synthetic cannabinoid use. Unfortunately, components of synthetic cannabinoids change rapidly, making them difficult to test for. While assays have been developed, they are often of low sensitivity and not readily available. As such, synthetic cannabinoid-induced AKI is currently a diagnosis of exclusion. The mechanism of injury is unknown, but prior reports of patients who underwent renal biopsy reveal acute tubular necrosis as the most common pathology. It is not known if certain populations are predisposed to this condition, nor is it known what the causative compound within the synthetic cannabinoid is. The phenomenon has been shown to cluster in areas with the same supply source, suggesting that specific formulations are more likely to cause this condition. Unlike other toxic ingestions which may have antidotes, the management of synthetic cannabinoid-induced AKI is supportive, with some patients requiring temporary dialysis. Other toxic effects of synthetic cannabinoids are wide-ranging and can complicate a patient's presentation and management. Identification of this condition is vital, as patients must be counseled on the importance of avoiding both synthetic cannabinoids and cannabis products of unknown composition. Thank you to the Florida ACP for allowing our author team to share this interesting case. We welcome any and all discussion via Twitter or email. Thank you.